Thank you very much for the opportunity to do this talk today on our paper titled HIPS, High Intensity Physiotherapy Following Hip Fracture is Safe and Effective in Reducing Hospital Length of Stay. This paper was published in the MJA in 2016. I thank the co-authors Sue Liu, who's the head of orthopaedics at the Alfred Hospital, Jim Sayer and Anne Holland, member of the Alfred Hospital Physiotherapy Group. My background is that I've been an acute hospital physiotherapist at the Alfred in Melbourne for more than 20 years. I won't age myself any further than that. And I mainly work in the area of trauma and orthopaedics. I completed a PhD in 2016 titled Assessing the Discharge Disposition of Trauma Patients and its Influence on Patient Outcomes. I'm sure the background to hip fracture, everyone who's listening to this knows, but there's rising rates. We've got an ageing population and they're actually very expensive. In Australia in 2016, we had over 20,000 hip fractures annually, and the direct and indirect hospital cost is estimated to be more than $900 million. Interestingly, fractured neck of femurs only account for 14% of osteoporotic fractures, but up to 72% of costs. And this is mainly associated with significant inpatient bed days. The mobilisation guidelines from the NICE guidelines from overseas suggest that we offer a patient a physiotherapy assessment and mobilisation the day after surgery and at least once per day thereafter. There's no recommendation with regards to the intensity of physiotherapy. The Australian New Zealand Hip Fracture Registries in their mobility guideline state something similar. A patient with a hip fracture is offered mobilisation without restrictions on weight bearing the day after surgery and at least once per day thereafter. We actually published an article back in 2006 titled No Rest for the Wounded, Early Ambulation After Hip Surgery Accelerates Recovery. Leonie Oldmeadow was the primary author on this paper. And this paper looked at two groups. One group that just sat out of bed within 48 hours post-operatively, and the other group that mobilised within 48 hours post-operatively. By mobilised, we stated that that was 3 metres. And the group that actually mobilised within 48 hours, at 7 days, they had accelerated recovery. They walked further and they were more likely to be discharged directly home, and less of them went to slow stream rehab. So I think that some of the mobility guidelines is actually based on this first paper from 2006. What about intensity? So there's one paper that looks at intensity of acute hospital physiotherapy in the neck of femur population and showed that it was associated with home discharge, but this paper was not randomised. We published a paper titled Pretty, which involved the trauma population at the Alfred Hospital. And we looked at one group that had intensive physiotherapy, 3 times a day physio, compared to once a day physio. And this paper showed that there was accelerated mobility outcomes within the first post-operative week. But we don't know whether these positive findings could be extended to patients following fractured hip and whether there's any long-term effects of early intensive therapy for fractured neck of femurs. So that's where our paper comes into it. Hip for Hips, published, as I said, in the MJA in 2016, with an associated editorial by the then head of the Orthopaedic Association, as well as by Jackie Close. And I'd like to thank the Department of Health for providing funding to allow for this research to be completed. The aims of the RCT was to investigate the effect of providing a more intensive physiotherapy program to patients over the age of 65 with an isolated hip fracture. The primary outcome measure was functional mobility at day 5. We used the Mileway, and I can go through what the Mileway is in a moment, and that has since been shown to be valid and reliable in this population, both in the acute hospital and actually in the subacute hospital as well. Secondary outcome measures included hospital length of stay, discharge destination, the TUG, in-hospital complications, and interestingly, we were told by ethics that we had to include pain and opioid medication use, as that they felt that we may cause increased pain to our patients by mobilising them more often. We also looked at 6-month outcomes, including readmission and patient-reported outcome measures through the Victorian Orthopaedic Trauma Outcomes Registry. This is the Marlowe on the screen here. You can see that there is 6 different elements that we look at. The first 4 are measured from independent at 0 to failed and not tested 5 and 6. We also include a walking distance and what gait aid they use. 0 is completely independent, 40 metres with no gait aid. 36 means that they were unable to get out of bed due to medical reasons. So essentially, close to 0 the better for the Marlowe. The inclusion criteria were patients over the age of 65 with an isolated hip fracture. We excluded those with a subtrochanteric fracture, pathological fractures, if they weren't allowed a full weight bear postoperatively, and if they were admitted from a nursing home. There were 2 groups, a usual care group who received once daily treatment of approximately 30 minutes by the physiotherapist, that was 7 days a week, and the high intensity physiotherapy group. This group received 2 additional treatments, one by a physiotherapist and one by an AHA. We used a randomisation via computer, and the usual care physio, the AHA and the day 5 assessor were all blinded to group allocation. This is our consort diagram here. You can see that we assessed 170 patients for eligibility, excluded 78 of them, 10 refused, and the rest didn't fit the inclusion criteria. All 46 in each group, they all received discharge outcomes, and most of them also received or gave us 6-month outcomes through VOTOR. The demographic data. So the groups were similar in all areas except for carer at home and anaesthetic type, which I've highlighted. Thankfully, this actually fell in the right direction in terms of the high intensity therapy patients. More of them did not have a carer at home, so therefore probably had a greater issue in getting home, and less of them had a spinal anaesthetic in the high intensity physiotherapy group, and there is some evidence that those with a spinal anaesthetic do better initially post-operatively. Here are outcomes. You can see in the first row that there was an increased length of stay in the usual care group compared to the high intensity physiotherapy group of nearly 1.5 days. This was not statistically significant, but again highlighted there was a 10-day difference in the combined length of stay, acute and rehabilitation, and this was statistically significant. Our primary outcome measure, the Marlowe, did not reach statistical significance, although the scores were lower, so better in the high intensity physiotherapy group. Looking at the other outcomes such as complications, there was no difference in the complications, no difference in the readmissions. In terms of discharge destination, more patients did go directly home in the high intensity group, over 20% of them, compared to 11% in the usual care group, but this was not statistically significant. In terms of pain, thankfully ethics were not correct, and the patients who received high intensity physiotherapy did not have higher opioid use or higher pain scores. We did do a Cox hazard model just to have a look at the probability of discharge, and we did control for gender, care at home, stairs at home, and anaesthetic type. And you can see from this graph with the usual care group sitting on top is that they were more likely to be still an inpatient at any time point across the model. 6-month outcomes, there were no difference between the 2 groups in 6-month outcomes. We obviously weren't powered for this outcome, and you can see that there were slightly more patients reporting a good functional recovery in the high intensity therapy group, but again, no difference in, no statistically significant difference. So in the discussion, if is safe and effective following fractured neck of femur, we did see a significant decrease in hospital length of stay in the high intensity group with no increase in complications. And this really represents a really important cost saving given the large numbers of fractured neck of femur patients which are increasing and the high cost associated with their care. Our primary outcome, as I said, the Marlowe, did not reach statistical significance. We do hypothesise that maybe day 5 was a little bit too early to show a change in functional mobility in the patient group, as their average length of stay was a lot longer than this. So perhaps measurement of function at increased time points is recommended. So it's nice to know at what point in time they did start showing a statistically significant difference between the two groups. The strength of the study include the robust study design, the relation and the blinding, and also the excellent follow-up of our patient group. So in conclusion, intensive physiotherapy program in the acute hospital does significantly decrease hospital length of stay by more than 10 days, with no difference in complications, readmissions, or 6-month outcomes. So the question should be posed, should hip fracture mobilisation guidelines be updated based on these results? So I think we just have to consider that these are relatively small numbers, and the therapy was only administered in one hospital, so it was a single institution trial design. And it's also, the generalisability is also limited because most patients were from home, so we had very few from residential care. There is no cost analysis provided, although the benefit of this large difference in length of stay is very clear. So what did we do? Well, we had a look at how many patients we actually had at the Alfred with a neck of femur fracture that were not from high level care. And there was probably about 240 patients in 2014. Like everyone else, it's gone up from there. But if you have a look at the potential savings for 240 patients of 1.4 days in the acute hospital, or 10.6 days overall. 10.6 days overall is 2,544 beds. And it depends how much you say a bed day costs, but even if we talk about $500, which is quite low, that's over $1 million worth of saving. And how much would we have to spend in order to achieve this saving? Well, all we need is an extra 1 hour of physiotherapy per patient per day. And actually the acute hospital length of stay was 1 day less in the high intensity therapy group. So it would cost for 240 patients about $57,000. So $57,000 in order to save $1 million per year. So thankfully, when we put that to the hospital executive, and as you can see, it did take us a little while and a bit of pushing, but we did get the funding provided for the 7-day service to these patients from August 2016. We collected data for 1 year after that, and we had a look at the patients that were discharged home and the length of stay. And they were maintained in terms of they were very, very similar to the high intensity physiotherapy group in the study. We did try to have a look at whether there was certain groups of patients who would benefit more or less from this acute intervention. And the 1 year data really didn't have a signal in that direction. We probably need to collect a lot more data in order to work out which patients will benefit. We also gained ethics last year to include the Alfred data in the Australia-New Zealand Hip Fracture Registry. So we will be on board. We're just checking the integrity data at the moment, and then we will be submitting it to the Australia-New Zealand Hip Fracture Registry. I think that there's a real opportunity for future research, as I said earlier, just to determine which patients in particular will benefit from this increased input. Perhaps a longer intervention. So this intervention was only in the acute hospital, so only while they were in the acute hospital. When they went to inpatient rehab, they did not get intensive therapy. We need, as I said, a more regular functional analysis, functional outcome analysis, such as the MILOA in multiple time points. Multi-centre trial would be fantastic so that we could say it was generalisable to other centres, and of course a detailed cost analysis. I'd very much like to thank Department of Health for funding this research, the Only Old Meadow who started us on our way, and then the Alfred Physiotherapy team, Orthopaedic Trauma team, VOTOR, and all my co-authors. And thanks to the Victorian Division of the AMA for the 2016 Sir Richard Storr Memorial Prize for this paper. Thank you. And I'm very happy to take any questions. Probably easiest to catch me on my email, which is on the screen, as you see. So if there's any interest in this paper or interest in ongoing research, it would be fantastic to have a chat about it. Thank you.